Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners working with older adults be the best they can be. And now your host, Mandy Chamberlain.
Hey guys, before we get started, I wanted to invite you to a free occupation-based 5-day challenge that I'm hosting starting Monday, March 19th. At the end of the challenge, you're going to be walking away with an occupation-based kit that you can use in your practice. You'll have lots of treatment ideas, resources, handouts, connecting with hundreds of other OTs and OT practitioners that are in the group. And, the goal is to make sure you feel more confident in implementing occupation-based therapy ideas with your patients. And of course, no challenge is complete without some giveaways. So I want to help you to disrupt the norm, throw away that rainbow arch, and get occupation-based. So sign up at seniorsflourish.com/occupation-based challenge. That's seniorsflourish.com/occupation-based challenge. Welcome everyone to the Seniors Flourish podcast. My name is Mandy Chamberlain. I'm an occupational therapist, and I like to talk about everything about occupational therapy and working with adults and older adults. And today we are talking about coping strategies for pelvic pain in the older adult. And my guest is Allison Landry. She's an occupational therapist. And I just wanted to welcome you, Allie. I'm glad you're here today.
Good morning. Thank you so much for having me. I'm definitely excited to expand some knowledge out there with the other occupational therapists in the field. So thank you so much for having me on this morning.
Oh my gosh, of course. This is a topic that I am super interested in because it's not a topic that I feel very confident in myself. So I love talking. That's one of the reasons why I love doing the podcast is I love being able to talk to other OTs that have much more experience and knowledge in these areas. And then we get to share the OT love with everyone else.
Yes.
Yeah, so it's great. So let's just start. Allie, I always like to kind of get my guest's background and kind of listen to everybody's OT journey because everyone is so different. And I'd love to hear yours.
Yeah. So initially I started out when I got out of college at an acute care level 1 trauma center. So I was fortunate enough to work in the neuro and trauma ICUs for a while. There were step down units, and acute care was about like a 900 inpatient bed facility. So I got a lot of exposure to like walking vent patients, multiple medical comorbidities, lines, et cetera. So that was a great job out of college. Then I transitioned to the current company that I'm with. So I took like a traveler position where I worked in acute care, acute rehab, subacute SNFs, and home care. And currently I'm practicing in the home care field. So I feel like I've been really blessed to be able to expose to the continuum of care from acute, all the way to home care, which has been great.
Yeah. That stuff helps. I think it gives you a bigger picture also of like what OT's role is in each of that, and then how you can best help with discharge planning. And I mean, I don't know. I think I love the continuum.
Yeah. And more too, like referrals. Initially when I started in acute care, I wasn't really familiar kind of what the resources were for home care specifically. So being able to work in different fields, you can see some areas where you can advocate more, or how you can collaborate with your other team members, your PTs, your social workers, things like that. So I think it just really helped expand my knowledge base and help in areas to advocate that I thought there were more deficits that could be addressed. So
definitely.
For me specifically Manny.
No, go for it. You specifically.
Pelvic health. I actually got into this line of work for being a patient on the patient side of things. 5 years ago, I was diagnosed with pelvic pain, specifically known as vulvodynia. And I'm not for sure if you've ever seen the show House. Yes, I love the show. And anyways, I was like a house patient. I unfortunately went to 6 specialists. Every time I went with my symptoms of what was going on, they were really not for sure what to do. That was very frustrating being on the patient side of things because over that period of time, it was a year. So as you know, with chronic pain, the longer you're in it, more symptoms and physical and psychological components interact. So Fortunately, I had a friend who actually set me up with my husband. So I'm very fortunate to her.
Oh,
she
nice.
sent me to a pelvic health physical therapist. And this woman saved my life. She got me referred to the right pelvic health specialist. And then from there began my journey. I've seen a hormonal specialist. I worked with a pelvic health specialist. I did intense pelvic health physical therapy for a while. I saw like a counselor therapist, and I worked with like a compounding pharmacist. So I had an A+ team. So going through that, what was really frustrating is I felt like there was a lot of stigma and shame because, talking about pelvic health with certain people are open, and some people it's kind of like, I don't want to talk about that. It's an uncomfortable topic. There seemed kind of some stigma. So for me, I'm really passionate at this point on increasing the awareness and what resources there are. I don't have kids, but I always hear a lot of my friends are, after you have a kid, if you're doing exercise, right, or you're running around, they're like, oh, it's okay. You'll, have episodes of incontinence. That's just part of being a mom. And I want to change the mindset of that of, those things can happen, but there are resources out there to help other women and men with pelvic health dysfunction, work on some of these areas that are impacting their ability to socialize or feel comfortable doing things. And I think just having the patient side of things is going to it brings that passion, as well as just understanding some of the areas that we still need more work on in this field of line of work, I should say.
When you have that, I can just think about my own experiences. When you have those personal experiences, let it be you or a family member, that level of passion just is just inside you, wanting to come out, and you can see how it can be, where your skill set can be so beneficial to others. It's just the awareness and getting it out there is always kind of a tricky part of it.
And currently right now, for all of Pennsylvania, I am the resource support coordinator for the National Vulvodynia Association. So I've been really blessed with that opportunity. Anybody who reaches out to the NVA, they contact me, and I work with these individuals on, I say kind of redirecting and streamlining to get the right professionals that they're looking for. So, depending on what they're going through, severity of the condition they have, location where they live, what resources are available. So working with them on that and expanding my knowledge base, which has been it's been a great journey. I've had a lot of support and people that are really receptive. And there's also, I'm taking Herman and Wallace out there. They have a lot of pelvic health courses. So I'm taking Pelvic 1 this March in Flagstaff, Arizona. And then I'm going to go to Tampa this January to do, it's like a mindfulness and holistic treatment to patients with chronic pelvic pain. So I'm taking that to expand my knowledge base.
That sounds great. How do you find working in home health and your patients with, pelvic pain in older adults? How does that
So what I see working in home health, there's the specific causes and symptomology can kind of vary, right? So some cases are going to be a little bit straightforward. Others, there's some overlap, whether it's muscular tightness, they're having some, whether urinary or fecal incontinence, is it specific performance patterns or behaviors in their everyday routine, and what are their knowledge of the patient and their current team. So for example, to make it a little bit more relatable, you have a patient that wants to go out in the community, right? You're working with them, but they're having increased episodes of urinary incontinence, and their doctor just prescribed Lasix because they have CHF and they've got all this swelling and edema, on their body. So working with them of how to regulate taking their medications, having like a voiding schedule, what dietary whether liquids or food components can lead to irritation of their bladder and cause them to have to go more often. And then if they're going out to the community or just in the home, how we can work on preventing having an episode of incontinence and how to empower them and feel comfortable with getting back out into the community and working in their home.
In general, are you being referred to patients just as a general home health therapist, and then that is just an additional issue or something that they are talking about, or are you seeing them specifically for
Great
pelvic
question. So
pain or
I'm not
incontinence or those
specifically
kinds of things?
seeing just, pelvic pain, incontinence, but there will be other issues. So they're coming in, they had a stroke or diabetes, or they're having an exacerbation of CHF or COPD. But then as we get to know the patient and I work on looking at some of their ADLs, so toileting, or they're having chronic pain that's leading to them not wanting to perform their ADLs, or they have such a fear of the stigma or psychosocial components with having an accident in the community. How can we get them back to that? So I feel like working on those issues from the patients that I've had experience takes a little bit of time to develop that rapport, get comfortable, and talk about those issues. Because a lot of times they're uncomfortable. They felt like they brought it up maybe to their general practitioner or other people, and some of the feedback has been, maybe it's just because you're a little bit older or that's what your experience. So I want to debunk that stigma and work on, here's some resources that we can work with you on. And for stuff that's, outside of my scope of practice, or that you would need another specialist on, I think just kind of working with your team members too. So, are they seeing an OBGYN who specializes in this, or do we have somebody that they could see for the pelvic pain that is more knowledgeable and would know how to work with those issues? So kind of expanding that referral base.
Yeah, referrals are huge, and knowing who to refer to and when is so important. Yeah. Oh gosh. How would you define chronic pelvic pain, like in older adults? What is that definition?
No, that's a great question. That question, I call it, it's like a pain cycle, right? So it starts out, you have your pain, and then that leads to like muscle guarding, right? Because you're uncomfortable anytime you're in pain. Then you may have like some spasms or chronic inflammation. Then a lot of patients you'll see restricts their mobility or doing things because they're uncomfortable, right? And when you're in pain, you don't want to maybe participate in things. Then that could lead to the weakness and their specific function. And then that also jumps into like anxiety, fear, frustration. So I call it the chronic pain cycle. And it can be consistent, and it can be really difficult for patients to know how to get out of that.
Yeah. Chronic pain is just a really hard topic anyway. And then you talk about, pelvic pain on top of that, where it may be a super uncomfortable topic, like you were saying earlier. And it's like, I don't know. That's why I was saying like this is a topic that it's really challenging for me, because you have a specific type of chronic pain. Like I almost feel more comfortable dealing with even maybe like a back chronic pain. I think because some people are not very open about discussing pelvic health. And some are great. And so then those are the ones that you could, but it's like when you're trying to pull teeth and they trying to have these conversations, I don't know. I just find it really challenging.
And like you said, like personally, if you have back pain, sometimes somebody who has back pain, or we'll see has abdominal pain, I feel like there's multiple layers. And so usually there's some component that it's connected to, that whether it's chronic pelvic pain or just pain in general, and it all kind of interrelates. So kind of breaking down the specific components of seeing what's causing all of this, where is it starting from, how's it affecting the patient on many levels, which a lot of people maybe sometimes, like we say as OTs, we want to look at the whole picture and not just focus on that one area, where sometimes other maybe professionals or just in general, they're kind of missing out on things that we could see that are contributing or could help with treatment.
So is there some common types of causes? Like you were saying, as an example, back pain may cause some abdominal
specifically pelvic pain. I'm thinking about like somebody who has maybe recurrent infections. So they keep getting a UTI, or they have like a chronic yeast infection. And that can really span, into a bunch of things. Then also there could be, whether it's hypertonic or hypotonic musculature of the pelvic floor, or a combination. There could be somebody who has chronic stress in their life, maybe some past trauma. One thing I thought about, and probably a lot of us can relate to, is our performance patterns, right? We we at work are really busy and we wait last minute to go to the bathroom, right? Or we know we have a long trip, we're going to get in a car or on a plane or something, and we're like, oh, I got to go to the bathroom just so I don't, have to go while I'm on the train or in the car, and kind of breaking those patterns that we've gotten used to over time that we don't even think about.
How do you, when you're talking with like your patients that have these types of symptoms, how do you quantify, pain levels? Do you do it the same way as you would any other kind of pain?
Absolutely. I think with the pain level, right, pain can be so subjective and it varies among different patients that you work with. So I try to really work with the patient on what they can quantify, what makes the most sense to them. So is it numerical, 0 to 10? Is it, if the Wong-Baker scale, I say you always see that usually in the hospitals, kind of the faces. Is it more of a verbal scale, the none to mild, moderate, severe? What thing I've utilized too, in addition to those scales, is I actually have, and I've used myself as a patient, I have them use like whether it's a diary or a log to monitor like what's going on in their daily activities, and starting to see if there are certain causal factors that are contributing to that pain. The majority of patients, not all, but you'll see stress really exacerbates that pain. So are there certain times of day that their stress is going to flare up more, or they have too much on their plate? And then with that, they can kind of get more of a visual of what's causing this and what we can do to be proactive, to prevent this or modify that pain that's happening.
Yeah, looking at those daily patterns. Yeah, and because I will have to say also that I find patients that have chronic pain, it's really challenging for me personally. I'm just going out of how personally is like just they have a different perception of pain also, and maybe this is something you can kind of touch on, but it's really hard when you're trying to get a good, using the faces or using a numeric scale or using those different types of scales. And, they're saying I'm a 9 out of 10. And you're like, well, like they have a hard time because they live with it day in, day out, trying to quantify that a bit. And so I think that's a really good idea to break it down and try to find the specific patterns and pinpoint that pain times a day or whatever that may be a little bit more specifically. And I think from my standpoint, I can see that being so much more beneficial for me as like a generalist OT, that I can maybe intervene at those different times a day or activities, versus trying to just get an overall picture of,
right.
Today I had 9 out of 10 pain. You're like, oh, okay. Or do you know what I mean? Like trying to be able to quantify that a little bit more specifically.
You're right on par.
Is that
something I also look at is the types of pain, right? So is it continuous? It's constant. There's no interruption. Is it intermittent? It can stop and start at specific intervals. Is it occasional, right? Maybe certain times of the day, the morning versus the evening. Is it brief? It's short in duration. So really kind of breaking down pain, because I think pain in itself, again, having experiences, it can be paralyzing. You are constantly anticipating it. You're scared to participate in anything.
Oh, yes.
And then your brain, starts thinking about that pain, and you start, I'm starting to feel symptoms. So I think really working with them on quantifying the pain as best they can, but also working with them on the tools to manage their pain. And once they can see that they can manage this, I think that gives them empowerment. So when the pain comes up, okay, this is what I'm going to do. I'm going to kind of ride this out. I'm going to do these things until it kind of calms down. Or I can get my pain from a 9 out of 10 down to a 4. And this is how I can get through my day. Instead of saying, I don't want any pain, that's hard to get to that.
Yeah, no, absolutely. And it's the, as the psychosocial component as well. It, like you said, it's a cycle, and it's like the anticipatory. You're anticipating the pain coming, and then avoidance of, ADL, IADL activities, and it's that crazy cycle. But yeah, being able to kind of pinpoint and break it down a bit more would definitely be more.
It really comes down to
beneficial.
I think about those like client factors, their values, their belief, their body image, self-esteem. If they're starting to feel like, they're having this pain, they can't get answers, and oh my goodness, what's going on with me? And they start to maybe get depressed or anxious. And all of a sudden you can see how that cycle will negate to, I'm not going to go out this week to socialize, if I have an event coming up, or I need somebody else to start getting my groceries out in the community. I don't want to participate in my daily tasks. You can start getting more isolated and scared to participate in maybe your hobbies that provide that pleasure and enjoyment. And so we want to get back to participating in those activities, whatever that could be. I'm trying to think. And then also too, just kind of working with them in the environments. If they have pain, how do we modify it? So if they're going out, they want to do dinner, or they're having friends over and they're hosting something, are we having them use specific modifications, certain sit pads to sit down on, or maybe finding a way for them to stand instead of being in that prolonged sitting position that causes that pain? So just kind of working around different things, like you said, with that framework, breaking down the components. We're so good at activity analysis. How can we modify and work out the kinks so that we can still get them to participate in these things that they really enjoy?
Oh, those are great examples. So is that kind of how you go about when you're trying to address that? If you're, I'm thinking about it from like a generalist OT standpoint.
Are they having increased urinary or fecal incontinence? And then is this difficulty with that incontinence creating fear for community integration for like the IADLs? Maybe even certain clothes, tight pants, jeans, leggings. Those can irritate if you're having chronic pelvic pain. So some modifications, what could they wear? Also, even down to the type of underwear that people wear, right? We want to make sure they wear cotton underwear. Also, if they need some assistance with changing their clothing, how do we work on that? If they have, I'm looking like difficulty for prolonged sitting, generalist standpoint, right? So looking at the ergonomics. If they have something they volunteer, they're still working, or they have in the job in a community and they have to sit. What are, some sit pads that we can utilize? Can we have them stand? Can we modify that? If they're driving, they have to get somewhere, or they have a long commute, what can we modify within the car so that they can participate in that? Hobbies, any high intensity, if maybe they're a long-term runner or they're doing some lifting, biking, how we can modify those components. And then also the other thing I want to talk about with ADLs, their sexuality, their intimacy, if they have the partner themselves, how they can participate, with that at this point, with not feeling stigma. And if that area is causing a lot of pain, how they can engage in that activity where they're feeling like it's probably the last thing they're going to focus on. So how do we engage in that, which can create, some stress or strain in their relationship or with themselves, feeling their body image and their self-esteem. So how do we work on that?
Yeah, those are really, really good. Kind of really on a side note, do you have any recommendations?
It's smart roller pads. You can get them for, I think it's like $10.99 without shipping on Amazon. So that's which is great. I don't know if you've heard of the Squatty Potty.
Oh, yes, I have.
Great commercial.
And I love the commercials.
Attention. So something else I thought about, the geriatric population constipation. Again, some people don't want to talk about it. So looking at modifications, I always thought about in home health. Sometimes I'm a shorter person. So if I'm on a commode, my feet, can't touch the ground. So the angle is not helping with having a bowel movement. So Squatty Potties, people can purchase if they do not have the means to get that. Do they have a stool? Do they have a couple books, something they can do to elevate so their knees will be higher, than the pelvis, so they can assist when they need to have a bowel movement. So that's something I recommend. I was just going to say, let's kind of, if you're not familiar with the Squatty Potty, and you kind of give a description, but basically it's like a stool that goes around a toilet that you put your feet on. And it basically, like you said, just has boosts your knees above your pelvis. And you don't even think about it. It just changes, the setup of when you're going to the bathroom, because most people are straining. They have a timeline they need to go to the bathroom. So working on ways to decrease those patterns that they've probably gotten into, not even thinking about it for a long period of time. Mm-hmm. Yeah, people really like them, especially when I did home health. I recommended them a lot, and people were just like, "It's the most amazing thing ever." But they really, getting people kind of help understanding. Initially, I've kind of got some back and forth. Are you serious? And so we kind of go about it and explain why. And also with that, stuff people can do at home, dietary modifications, increasing their diet. So OTs can work on, again, nutritional aspects with that, increasing their hydration. We have something I always give out. It's called like a bowel recipe. And it's a combination of, applesauce, some prune juice, and wheat or oat bran that we work with them on to assist with helping to prevent constipation and just having more regular bowel movements. So, something that they can utilize and make part of their daily routine.
Mm-hmm. Yeah, definitely. Yeah. How do you do goal setting?
Specifically for goal setting, always client-centered, right?
Interventions.
What's the client's long-term goal? I try sometimes to break it down maybe from short to long-term goals. So if somebody has urinary incontinence, right, maybe initially working on like a bladder voiding schedule. So we can have like a log, and we have them every 2 hours, or 3, depending on the specifics, going to the bathroom. So they're not having to rush, right, last minute running to the bathroom. Working on some bladder voiding techniques. So, again, like we talk about, if you have a busy day, the last thing you're doing is you're rushing to the bathroom. So, or if people have urge incontinence, they feel like they really have to go, working with them on ways to make that a little bit easier. So, having them go frequently to the bathroom, taking their time if they feel the urge to go, just gently walking to the bathroom, don't rush. Working on some diaphragmatic breathing, just taking some nice deep breaths, right, where you're inhaling. I always tell people, take your hands and put it on your belly. So you're going to have that expansion coming out. And then when you exhale, right, your belly's going to kind of come in. So working on that. And also avoiding we called like the just in case. I got to use the bathroom before I have to go on a long trip. So avoiding those patterns you kind of get onto. And also I never thought about this, sitting on the toilet completely, not hovering over the toilet. So I know a lot of people, sometimes if they're out in public, you don't want to sit on the toilet. So do they have something you can sit down on in between, or can we find a place you feel comfortable to utilize something to sit down? And then yeah, I didn't think about it until kind of going through that. And then
never thought
long-term goal would be maybe, expanding to, can we decrease the number of episodes of incontinence that they have? And really, can we get them comfortable to go back into the community, or to host people at their house without worrying, I'm going to have an episode of incontinence and I don't want to become embarrassed. That's an option.
Yeah, definitely. And, I think it's something to kind of keep in mind is sometimes you don't always have to have a goal of something specific to, pelvic pain or that can be a component of your long-term goal. Like your long-term goal can be, like you said, reintegration of, participating in, I don't know if they like to go play cards with their friends or whatever it may be. But, you have to look at all the components that go into that. And if incontinence is a big barrier, it's something that we can work on in order to achieve that goal. So I think sometimes people get, I get a lot of questions. I mean, I get so many emails anyway about all sorts of questions and goal setting specifically, and writing goals and that kind of thing. And I think sometimes we just have to look at what are the occupational performances that are impacted, and we can write just some of those goals and look at the components that go into that. So, but yeah, that the pelvic pain and incontinence and that whole thing is really modifies people's life, and it's definitely something that I've been passionate in the last year, since I've been learning so much more about it, that we need to be addressing it. Because I think sometimes we actually will ask them about it, like during an evaluation, and be like, oh, do you have any urine incontinence or bowel incontinence or, pain or whatever we're talking about? And then they say, yes, I, wear a pad or whatever. And we kind of don't always address it. And we need to be addressing it, or we need to maybe be referring it to someone that we feel is more appropriate.
I think it's an
if you don't feel like you have the skill
area
set
in OT that we're addressing, and and looking at our role, right? I know I have a lot of friends who are pelvic health physical therapists that do a lot more manual work on patients, which, they're great with that. And they work on those components. We've got our pelvic health specialists that work on more medications, if they need injections, Botox, that aspect. You've got your compounding pharmacist, you've got your therapist, hormonal specialist. But I think as OTs, we can really work on how can we modify the environment, what specific areas is this chronic pain, impacting their ADLs or their IADLs, and how we can add our voices and empower our patients. I think the more people we have addressing and working together as a collaborative effort, we can assist and really empower patients to know that there are resources out there. Because like you said, I think a lot of people just talk about it. They think it's something I have to live with. It's uncomfortable. And we need to just shift the mindset and really empower them.
And also, I think something to kind of keep in mind, I did a documentation series in the podcast, and I'll actually link the series in the notes or in the show notes as well. But I was talking to Cornetti and Kraft. They really specialize in documentation, and they specifically home health, but they kind of know all the Medicare, Medicaid requirements and this and that. And one of the things that really stuck out to me about that that series was one of the things that they were talking about is how if we ask a question and we know an answer and it's not being addressed, it doesn't necessarily have to be us, but it is our responsibility as occupational therapy practitioners to, make sure that we are, if we're not addressing it, we need to be referring. And I guess I just kind of reiterating that. And so it's not even just that we should be doing that, quote, as OTs, but like we have an ethical obligation.
We've got more research. We've got more ways to really improve the awareness. I think a lot of people are just not familiar, or, I'm not a specialist, so I'm not really sure how to handle. So how do we support our OTs? How do we get the information out there? Hey, these are where you can look for referrals, resources. If you've encountered this, reach out to your fellow clinicians. Let's work together. Because again, it's quality of life for the patient. And even though most people are really comfortable with referral for maybe somebody who had a stroke or for vision therapy or pediatrics, I think this is another area that we could really assist our quality of life, especially for the expanding population of geriatrics, baby boomers. We're going to have more interactions. So I think this is something that we could really work on and expand within our realm.
Yeah, absolutely. And even just like as a generalist, even just starting with the basics and, addressing it from that standpoint.
When we have a nurse or a physical therapist that goes out to do like an open assessment that has a patient they take on for home health, one of the questions is in the mock 10 to see if their fall risk addresses incontinence. And so we've been looking at that a little bit more. If the patient, does have a high history of falls, what I like is we're really addressing, with both OT and PT, but toileting nighttime, right? So are we making sure, again, if somebody has an infection or has increased urgency to go, do we have a commode or a urinal? Yes. Are we limiting the acidic content of food or liquids before night? Are we putting them on a voiding schedule? Do we have incontinence supplies for them to utilize nearby the bed if they're not able to get up? Is the caregiver comfortable? How can we educate them with that? So I think this is an area we're initially starting with, but we can keep expanding and working. We do for our therapists going out for OTs, we have our referrals for pelvic therapists in our network. So we work with them in the home on areas we can address. And if we feel that they have continued need, we have expanded our referral source so we can assist our patients with that. So they have that for the next continuum of care.
Oh, that's great.
Yes.
That's great.
Again, just really working with our therapists in the region, making them comfortable. Like anything, you start with something, and once we expand it, it can flourish, and I think could make a substantial impact with our patients.
Absolutely. Absolutely. And like you said, the baby boomers and, the older adult population is just going to be growing.
I actually had incontinence, and to me, it was baffling when this started. Like, wait a minute, I haven't had children naturally. I'm younger. What is going on? So really understanding, I know you always hear probably the word Kegels, right? Do Kegels. And so I really, with the knowledge we have out there now, really caution and say, please have all patients be evaluated
Right.
appropriately. And let's make sure there's not an imbalance, right? So they've got maybe too much tone here and not enough tone here. There's, an imbalance. We just want to make sure we're giving them the right information, because if we keep saying do Kegels and they have too much tone, they're going to keep having incontinence. So we don't want to be giving the wrong information. And again, that's really frustrating as a patient if you're like, why am I giving this information and it's not changing? Is there something I'm doing? You start to, it's kind of that chronic cycle. You start thinking about these things. So just making sure we're really relaying the right information.
Because there's lots of different, obviously causes. So it's like trying to give a general exercise to a shoulder issue. Like, it's not always going to solve the problem. And I think, and I actually think, you can explain, people can relate almost, and you can say, oh yeah, you can't give an exercise to a shoulder issue if it's not a rotator cuff problem.
I think just as our therapists, and what I'm working on is how do we expand that, within our group of practitioners, how do we throughout the OT workforce and field work together and get that information out there. I think just awareness to an area with a lot of stigma and something that people are uncomfortable. I think we're just going to keep pushing the envelope and expanding the information out there. So that's my goal.
That's a good one. That's a good goal to have. It's important and it's needed. If you were going to give a couple just like basic tips for like the generalist OT that has a patient that they're working with that has, some sort of chronic pelvic pain.
Are they hands-on? Are they visual, kinesthetic? How do they learn specifically? If they're having some limitations, do they have a caregiver who is receptive and can work with looking at these techniques? For some coping strategies, for the chronic pain, I'm always a big proponent of holistic. So yoga, Tai Chi, mindfulness. Is there a support group? What are their hobbies that they enjoy? I know we're all familiar with the autonomic nervous system, right? And we want to make sure there's a balance. I call it the autonomic quieting and balancing. And how, if you're having constant sympathetic firing, the system can change, and how do we get a rebalance? So what I look at is, for me, I've worked with somebody maybe like a calendar or a log, like a visual. So they can see how they can participate in these coping strategies. And maybe looking at how often, if somebody's like, well, I'm doing this technique twice a week or twice every 2 weeks, and I'm not seeing much carryover. If we have a visual reference to look at, well, let's try it 3 days a week, or if this isn't working for you, let's go back to the drawing board. Let's look at everything that we've initially started with. I think also too, addressing what are their specific goals, and really breaking those components down and looking at the environment, their performance patterns, again, their personal values and beliefs, their client factors, and what areas are most pertinent to work on, and how we can modify and work around that. And I think also it's very important to empower your patients that, we're going to work, we're going to modify. This is a trial and error. So if something doesn't initially work, let's go back to the drawing board. Because I think just a lot of the patients, chronic pain, they have not seen a lot of progress or have been in this position for such a long time that they're very uncomfortable. And a lot of people give up hope and are just sometimes even resistant to any recommendations. So always showing them that you're really wanting to empower them and help give them the tools so that they can manage this.
Exactly like you were saying, it's just trying to connect with them and have them understand that you are really trying to help, and that having that also, they probably have experienced a lot of trying things and nothing working. And so that you're really willing to modify and look at them from a holistic perspective.
There were a lot of specific components. So it was really hard initially to find what the cause was and how all these specific areas were contributing. So I think that's where people get lost in shuffling in the medical system. They get really frustrated because we try something, it doesn't work, but there may be a lot of other areas we need to address specifically to figure out what's symptomology, what are better coping strategies. And also too, if somebody's having like a flare up and they're in acute pain versus chronic pain, how do we differentiate that? How do we say what strategy works best? So I think just really building that relationship, understanding what's important to them, what support systems they have. I think that's another area I want to address. Just it can be really isolating. And again, a lot of people don't want to talk about this. So I don't want people to feel like, nobody else is going through this. I've brought it up. I'm kind of getting pushed to the side. There's no hope. You hear that a lot. So, let's talk about it. Let's get people comfortable with, especially if it's sexuality or if it's incontinence, urinary or fecal. How do we address those topics with appropriate bedside manner and making them feel comfortable? Because those are some definitely personal areas that a lot of people don't feel comfortable talking about to their significant other or to. And if I'm just coming and meeting you for the first time, that's going to be hard to tackle those areas sometimes.
Take home and try with our own in our own clinical practice.
Apps, Calm, CALM,
okay.
and Headspace, like the word head and space combined. They're two free apps that I utilize. I give out. They're great resources. They really just kind of focus on deep breathing, slowing down, being present in the moment. So those have been really beneficial for patients when I give that out.
Oh, great examples. Great examples. I'm writing those down, and I will also add those.
They can do colonic massage themselves. They can really start trying to get, if they are constipated, whether they're taking pain medications, right, for chronic pain, or, they have a fluid restriction. I think about that, right? So the amount of fluids they can take in, maybe because they have CHF or another medical comorbidity, they're limited. So how can we do another manual technique to help them with their bowel regularity? So that's something else that we work with them on. But it's something you can work with them on, again, making sure somebody assesses there's no contraindications, but something that the patient can empower and do for themselves.
That's a good one. That's a little tool I'm sticking in my pocket. I've actually never done that or seen that, but it makes complete sense. I can see how that could be super beneficial.
Tips for the trade and stuff out there. If anybody has questions or specific examples that want to be addressed at a later time, definitely happy to answer that.
Perfect. Well, thank you so much. Yeah, I'm going to add a lot of these resources in the show notes so people will be able to have the links and they can kind of check things out and see what would be beneficial for their patients. So I really, really appreciate that because I am a kind of like a resource nerd. Like I love having all my resources, handouts and everything kind of together. And I'm going to say somewhat organized because I'm maybe not being 100% organized, but like I love having those things at your fingertips and being able to give those resources to our patients. Knowledge is power. All right, everyone. Grab your resources, check it out from Allie, and I will be chatting with you later.
If you are an occupational therapy practitioner that enjoyed today's podcast, I invite you to check out the Learning Lab at seniorsflourish.com/Learning Lab. The Learning Lab is the essential resource for OT practitioners working with older adults looking for more treatment ideas, support, and resources to be the best they can be. So whether you're struggling to find evidence-based treatment ideas, you don't have time to research for resources or patient diagnoses, or are even looking for ways to earn more professional development units, then the Learning Lab can help you become a more effective and efficient practitioner. With weekly educational videos, a huge resource and handout list, a bi-monthly journal club where you can earn professional development units, a supportive community forum, and even some exclusive member-only bonuses, the Learning Lab is the perfect place to help you be the best OT practitioner you can be. It's like having your own OT help desk. So check it out at seniorsflourish.com/learning lab. Thanks for listening.